I represent MIT Critical Data, a consortium whose mission is putting data and learning at the front and center of healthcare. The consortium consists of healthcare practitioners, computer scientists, engineers, and social scientists who believe that data and learning are the best medicine for population health. We build communities across disciplines to derive knowledge from data routinely collected in the process of care in order to understand health and disease better and in the local context. Our group reviewed all manuscripts published in PubMed in 2019 on the application of artificial intelligence in healthcare. Given the consequences of an incorrect decision, high stakes medical algorithms need to be trained with data sets drawn from diverse populations. Yet, this diverse training is not happening. From a global perspective, majority of the algorithms are being trained and validated on data from only a handful of countries, further reinforcing the tradition of a medical knowledge system that feeds into health inequities. In the paper, we describe differences in database nationality, domain specialty, and author nationality, sex, and area of expertise. The figure shown here represents the country source of the database used to train and validate the algorithms. Only a handful of the countries are represented, with 40% of the manuscripts presented models trained on datasets from the United States. AI research has divided the world into data-rich and data-impoverished countries. Artificial intelligence is a codification of clinical practice and the medical knowledge system as it is developed from their digital exhaust. It is but an encryption of a clinical practice that leads to outcome disparities and a medical knowledge system that is derived from research that disproportionately represents a majoritized population. We need a better roadmap to leverage machine learning and derive knowledge from the zettabytes of health data that we collect in the process of care. And that roadmap requires data sharing at its core. When access to health data is limited to one group of investigators, there is no quality assurance of data curation. Wrong assumptions during the data curation leads to model misspecifications and flawed algorithms. What we get is AI that perpetuates and even magnifies health inequities. Algorithms developed by teams with perspectives that underrepresent most of the world are bound to maintain the status quo. We should not only invest in storage and compute technologies, federated learning platform, GRUs, GPTs, or NFTs. Our goal should be to build capacity across populations and diversity of perspectives in research. This is the biggest investment we should make.